Firstly, I just wanted to thank the organisers for allowing us to present our data from a project that we're running in Uzbekistan. Some of the background to MDR-TB treatment I think is very pertinent for those in the room that don't treat patients with that disease. The conventional treatment for MDR-TB is up to 2 years long. It's very complex medically for doctors and nurses to manage patients on MDR-TB treatment. The side effects are very significant, with up to 10% developing hearing loss during the treatment. And for programs, it's very expensive. Each patient, we think, costs around €3,000 for their treatment alone. Around 2010, a group in Bangladesh, the Damien Foundation, discovered a new regimen using conventional drugs, so no new drugs, but in a different combination, which allowed treatment to be reduced from 2 years down to 9 months, had lower toxicity levels, and was significantly cheaper. At that stage, there was very limited data about the role of this regimen. And so in Uzbekistan, we conducted a study to develop more data to hopefully lead to policy change. So Uzbekistan, for those that don't know, is in Central Asia. It's a former Soviet Union country, and it's on the list of the WHO's list of high MDR-TB countries. Amongst new cases of TB diagnosed, 23% are diagnosed with MDR-TB, and amongst patients who've had treatment for TB before, it's almost 2/3. I think importantly for the former Soviet Union, which is sometimes different to other parts of the world, there's very high levels of second-line drug resistance. So these are drugs that we kind of rely on for patients who have MDR-TB, with almost 8% having resistance, probably the most effective drug at that time, which is the fluoroquinolone group of drugs. So our study, so the analysis I'm going to present today is actually two analyses. It's comparing this shorter regimen that was discovered in Bangladesh with the conventional treatment that we were using at the time, this 2-year regimen. And so what I'm presenting is data around the early effects of the two regimens, so comparing people who had 2 months of the conventional treatment versus people who had 2 months of the shorter treatment, and also the end of treatment outcome to see, was the shorter regimen as effective or more effective than the standard regimen in this context? So the original study was a single-arm prospective study that we started in 2013. We restricted it to 3 districts, for logistical and operational reasons, in a program that MSF has run in collaboration with the Ministry of Health for many years. I think the program started in 1999. We started recruitment in September 2013, and this new regimen is shorter than the original. So 4 months of this combination at the beginning with an injectable drug every day, and 5 months following on from that with tablets. The inclusion criteria, I think, is essentially any patient with pulmonary MDR-TB, and we have an advanced laboratory there where we can use multiple tests to diagnose that. And the exclusion criteria is to exclude patients we think have that second-line drug resistance, because when the study started, we knew that they had a potentially worse outcome. So our comparison group, so it's important to know that this is an observational single-arm study. So the comparison is after the study finished. So for the short course regimen, we had those recruited and involved in the short regimen, so that prospective study. And then the conventional care group is other patients within the same MSF, Ministry of Health collaborative project, but in different districts. We restricted them to the same time period to try and remove biases involved in changing of the program. And that group received a protocolized WHO-approved 20 or 24-month regimen based on the clinician's decision-making. We looked at fairly standard outcomes for both analyses. The first one being the effectiveness of a measure of the effectiveness of the regimen at 2 months treatment, and then the final one being the final outcomes at the end of treatment. Baseline characteristics across both groups were fairly similar. I think the key part from this slide is to notice that this is a region with very, very low HIV prevalence. And in fact, we included no patients who are HIV positive in this cohort. And equally, disease characteristics, looking at the burden of disease, how severe these patients were. We looked at fairly standard TB aspects, so things like cavities on the chest X-ray, how much TB we discovered in patients' sputum, as well as some baseline resistance characteristics were all similar across the groups. And so I think the key parts coming to the results is the box in red. So comparing the two groups of patients in their early treatment response, we found that those receiving the short regimen had basically twice the effective response after adjusting for reasonable confounders. And in fact, at the end of treatment outcomes, we discovered that there was basically no difference between the groups. Obviously, that's comparing a treatment of 2 years versus 9 months. And so actually, we believe this to be quite a positive finding. Obviously, the fact that our methodology was observational, the analysis that I'm presenting today was in fact retrospective, raises a number of biases that I think we can't get away from. Obviously, it's non-randomized, but equally, we felt that it was valid given that the program is the same, the laboratories are the same, the outcomes are the same. And so we do feel that the biases, although there, are limited in some fashion. So in conclusion, we think the short regimen shows that it has good early effects in this patient group. We know that we found that the final outcomes at the end of treatment were quite similar, although that's with a much shorter regimen. And we think these are quite encouraging results from quite an established program. And in fact, last year, the WHO agreed with us and other groups performing similar analyses around the world and changed international guidelines to include the short regimen for certain groups of patients. So I think it's important to talk about the generalizability of our results. This is a context with high levels of second-line drug resistance and very low HIV prevalence. We do believe across that region of former Soviet countries that that's quite similar to other countries, and so maybe we can generalize to those countries. There's a question about whether this effect early on in treatment has a positive impact on transmissibility. We believe that having a shorter treatment requires less work and less costs for programs. And we're actually all looking forward to the randomized clinical trial that is occurring at the moment to give us valid scientific results. So just finally to thank all the patients and doctors and nurses who participated and obviously support patients with TB in this region, as well as our collaborators in Uzbekistan and Karakal, Pakistan, the region where we have this collaborative program. And I'll leave it there.